Hello everybody. So this is our continuation lecture of the last lecture which was acute exacerbation of the COPD, and in this we will discuss mainly with the ventilatory support in COPD patient. So the ventilatory support, the indication for ventilatory support in COPD patient include unsustainable increased work of breathing, severe hypoxemia, and exacerbation leading to hypercapnia and reduced pH less than 7.3. So regarding NIV, the main benefits associated with non-invasive positive pressure ventilation in acute exacerbation of COPD are lower rates of intubation, shorter length of stay, and lower rate of complication of invasive mechanical ventilation. So NIV has been shown to reduce the need for intubation, decrease the length of stay, decrease mortality, and in some areas conserve the precious resource of ICU bed. Patients with COPD who present with the exacerbation of hypercapnic respiratory failure with acidosis are the group most likely to benefit from NIV. Exacerbation increase the work of breathing, often exerting the patient's ability to compensate and result in hypoventilation. So increase intrinsic PEEP, dynamic hyperinflammation, and weakened respiratory muscle force combine to produce ineffective tidal volume. So NIV effectively unload the respiratory muscle, increase tidal volume, reduce the respiratory rate, offset intrinsic PEEP, and decrease the diaphragmatic work of the breathing. These changes lead to more efficient ventilation with improved oxygenation and reduction in hypercapnia. For effective treatment, an IV needs to be used for appropriate group of the patient, combined with treatment of underlying condition with bronchodilator, corticosteroids, and antibiotics. So the invasive mechanical ventilation. The indication for invasive mechanical ventilation support include reduced conscious level, inability to adequately control secretions, need for controlled ventilation with use of sedation, persistent or worsening hypoxemia and worsening respiratory acidosis despite supplemental oxygen, or NIV, hemodynamic instability, and need of vasopressin. The goal of mechanical ventilation is to provide adequate respiratory muscle rest, improve gas exchange, and allow time for exacerbation resolution while not causing further harm. So this is the figure 1, which shows the ventilatory interface showing the effect of minute ventilation, respiratory rate, inspiratory flow have on I ratio. So note that reducing the rate from 24 to 14 per minute increase the inspiratory flow from 50 to 75 ml, and I ratio changes from 1.16 to 1.5.5. Also note in the A that expired gas does not return to the zero, leading to the trapped air and intrinsic PEEP, inspiration, expiration, PEEP, and this positive end expiratory pressure. So ventilatory setting in general, the initial ventilatory setting are operator dependent and vary with the local practices. So we recommended initial use of assist control ventilation for invasive mechanical ventilation. Assist control ventilation is the most efficient at decreasing the work of breathing in COPD patients. A major issue during ventilation for obstructive airway disease is development of dynamic hyperinflation. This refers to the increase in end expiratory lung volume and pressure it exerts. Dynamic hyperinflation can be minimized by reducing minute ventilation, prolonging expiration to allow deflation, and by reducing airflow resistance with targeted medication. The aim of controlled ventilation should be to match minute ventilation to metabolic requirement while avoiding dynamic hyperinflation, lung injury, and extreme respiratory acidosis. It may be necessary to aggressively sedate the patient to achieve synchrony with ventilator and reduce tachypnea. When selecting tidal volume, it is important to provide sufficient volume to satisfy the patient and achieve synchrony with the ventilator. As guidance, tidal volume of 5 to 8 ml per kg are often used. When estimating appropriate minute ventilation, it is important to be aware for many patients with severe COPD, the baseline state is the chronic compensated respiratory acidosis. So in this patient, we aim to achieve the steady state PO2 because this reflects the balance of their central respiratory drive and the ability of their lung to ventilate. So this can be estimated from the stable blood gas record or serum bicarbonate. That is expected PCO2 is 1.5 and 2 HCO3 plus 8. So ventilatory setting that produces normal PCO2 in individual with chronic respiratory acidosis can result in significant alkalosis with its potential central nervous system and cardiovascular complication and difficulty when attempting to wean from ventilator. So optimization of I ratio will reduce the hyperinflation and in severely obstructed patient, 1 is to more than 4 is often effective. Adjustment of inspiratory flow to shorten inspiratory phase of the each breath can lead to better gas exchange by prolonging the expiratory phase and allowing more complete exhalation. In addition, reducing respiratory rate will elongate the expiratory phase and decrease the I ratio. So, as a guidance, the inspiratory flow rate between 70 to 100 ml are appropriate depending on peak airway pressures. So use of low tidal volume and high flow rate can lead to short insufflation time with risk of double triggering if the patient continues to effort beyond ventilatory insufflation. So the double triggering can lead to high tidal volume and increase in expiratory lung. In this situation, the use of long inspiratory time may resolve this. Other options include switching from constant flow to decelerating flow waveform, reducing peak flow, and by adding inspiratory pulse. The trigger for initiation of each breath depends on the mode of the ventilation chosen. For control ventilation, the trigger is time. However, during AC, the patient initiates breath, and this is thought to be more comfortable. The ventilator detects the change in the patient effort and trigger a breath in response. So the trigger types include pressure, volume, or flow. The pressure trigger, the patient must exert predetermined amount of negative pressure to elicit ventilator assist breathing. That is 1 to 5 centimeter of water. In flow trigger, the patient's effort decreases the bias flow in ventilator circuit by predetermined value, which initiates the breathing. So we generally use flow triggering because it was thought to be more comfortable for patient and can result in less work of breathing for some patients. Patients with dynamic hyperinflation have greater difficulty triggering the ventilator. This is because they first must generate sufficient force to overcome elastic recoil associated with increase in expiratory lung volume and then sufficient force to reach the triggered threshold. The level of intrinsic peak can usually be estimated through the ventilator. Static intrinsic peak can be measured in patients without active respiratory effort. The ventilator executes the end expiratory movement. This provides a measure of total peak by allowing lung unit with different regional time constant to equalize with the ventilator. The intrinsic peak can then be calculated by subtracting external peak from the total. For spontaneously breathing patients, the process is more complex and requires the use of esophageal pressure monitor and airflow tracing. Expiratory muscle activity and airway narrowing can all cause inaccurate measurement of intrinsic. Elevated intrinsic peak can lead to non-triggered breath that increase the work of breathing and sensation of dyspnea. In this situation, the addition of external PEEP set through the ventilator can decrease the inspiratory threshold load. In general setting, the external PEEP, which is approximately 70% of intrinsic PEEP, is effective in patients with the COPD. The reduction of non-triggered breath is a good indication of more comfortable ventilator setting. The clinical assessment of the patient receiving mechanical ventilation is important in detecting adequacy of the patient-ventilator interaction and respiratory status. Analysis of ventilator waveform can also provide vital information. Regarding weaning, the patient with severe COPD can prove difficult when trying to liberate them from ventilator. So COPD patient can develop significant dynamic hyperinflation during weaning as a result of tachypnea and expiratory flow limitation. This will lead to the respiratory distress and clinical signs of weaning failure. So all the patients should be assessed for appropriateness of attempted weaning on daily basis. So selection of COPD patient for weaning from ventilator from mechanical ventilation. So first criteria is resolution of underlying cause of respiratory failure. Second is stable hemodynamics without need for significant vasopressor. Third is stable metabolic rate, that is without sepsis and hyperthermia. Fourth one is cessation of neuromuscular blocking agent. Patient should be alert, able to follow command and protect their airways. Metabolic and electrolyte derangement should be corrected. Adequate gas exchange, that is PO2 FR2, should be greater than 200. Require minimal assistance from the ventilator, that is PEEP should be less than 5 and FR2 should be less than 50. Then adequate respiratory muscle strength. Many studies have reported the development of rapid shallow breathing in patients who fail to wean from ventilator. The degree of rapid shallow breathing can be quantified by calculating ratio of respiratory frequency to the tidal volume in liter. If RSPI is less than 1.105, then that has been shown to be the best predictor of the weaning outcome. It is important to recognize that this test is more accurate in patients who have received mechanical ventilation for less than 7 days. Now, regarding weaning method, there are two types of weaning method, and these are daily spontaneous breathing trial and gradual reduction of the pressure support. Daily spontaneous breathing trial have been shown to be safe and effective and faster at liberating patient from the mechanical ventilation. Comparing gradual PSV reduction and spontaneous breathing trial, current evidences does not indicate which of these is superior. We generally opt for spontaneous breathing trial using continuous positive airway pressure mode through the ventilator circuit to take advantage of ventilator alarm with or without PEEP for 30 minutes to 2 hours. At 30 to 120 minutes, if the patient looks favorable, then we will extubate to humidified oxygen to maintain O2 saturation 88% to 92%. We have low threshold for extubation to NIV in patients who are marginal as long as they can manage their own secretion and are mentally unimpaired and do not have difficult air. The development of rapid shallow breathing, asynchronous and paradoxic thoracoabdominal movement, accessory muscle recruitment during spontaneous breathing trial are physical examination findings indicating high risk of unsuccessful trial of intubation. When any of these findings are present, the patient should be placed back on the ventilator. Subsequently, there should be an assessment and correction of the suspected cause of weaning failure. Now, the next is tracheostomy. Tracheostomy is commonly performed for mechanically ventilated patients with prolonged ventilator-dependent respiratory failure. Reason to perform tracheostomy include provision of stable airway to facilitate rehabilitation, improve clearance of respiratory tract secretion, and in some cases, reduction of sedation. Sedation has been constantly associated with delirium and length of ventilator-dependent respiratory failure. In our experience, the tracheostomy often reduces the need of sedation because it can improve ability to communicate and reduce the frustration. This has to be weighted against the complication of tracheostomy, which include bleeding, fistula formation, infection, and tracheal stenosis. The use of tracheostomy as an adjunct to weaning process in COPD can be helpful for appropriate patients. COPD patient can occasionally require long period of mechanical ventilation to allow time for the exacerbation to resolve sufficiently to allow weaning. Failure of weaning from ventilator in COPD is complex to understand because it results from imbalance between respiratory muscle capacity and applied resistive and elastic loops. COPD patient can occasionally require long period of mechanical ventilation to allow time for their exacerbation to resolve sufficiently to allow weaning. Failure of weaning from the ventilator in COPD is complex to understand because it results from imbalance between respiratory muscle capacity and applied resistive and elastic load. Endotracheal tubes can be small in diameter and the development of biofilms and can further decrease the internal diameter, leading to greater resistive load. Several groups have studied the effect of tracheostomies have on the ability to wean. They found that tracheostomy significantly reduces the work of breathing, pressure time index, and measure of resistive and elastic workload. Now, regarding extracorporeal life support and extracorporeal carbon dioxide removal. Despite continued improvement in NIV, it is sometimes insufficient to overcome refractory hypercarbia and acidosis. In such a cases, the conversion to invasive mechanical ventilation is needed. So this self-selecting group has a higher mortality up to 30%. So mortality is increased because the patient is exposed to associated risk of invasive ventilation, including ventilator-associated pneumonia, prolonged mechanical ventilation, and difficulty weaning. So advances in extracorporeal gas exchange technology has led to the evaluation of system designed for the extracorporeal carbon dioxide removal. So the evidences from the studies would suggest the ECOR is an effective therapeutic modality for CO2 removal, but it does not change the long-term survival and there are associated with the risk. Complication related to the need for the mobility limiting large bore catheter, the need of anticoagulation and consequences of hemolysis, thrombocytopenia are associated with ECMO, all need to be considered. So the patient who develop hypercapnic respiratory failure, they are at severe end of spectrum. The use of such a life-saving modality should be seen as an indication for consideration of lung transplantation and initiative of palliative focus care plan. Then regarding nutrition, critical illness induces the high catabolic rate that can lead to loss of significant muscle mass. This catabolic state, prolonged immobility, and series of other risk factors, including possible exposure to corticosteroid and paralytic agent, can lead to the critical care polyneuropathy. So the awareness of loss of respiratory muscle mass and diaphragm weakness is extremely important because it can lead to difficulty weaning from mechanical ventilation. Nutrition should not be neglected for patients who are stable enough to feed. And nutrition should be balanced to meet the body's need and avoid loss of muscle mass. Unnecessary calories and excessive carbohydrate feeding can lead to carbon dioxide production that patient compromised respiratory system may be unable to clear. Thanks a lot.